And we're back. This is Unit 2, the second part of the PowerPoints. We're going to talk in this segment specifically about the electrolytes. Now, we're not going to talk about every electrolyte that there is. We're going to focus on three main electrolytes: sodium, potassium, and calcium. Now, a lot of the information that we're talking about, it's really what do you specifically need to know versus what would be nice to know. We're going to focus on you need to know this, knowing that later we're going to start building and adding more information to it. So we're going to boil it down and try to keep it very simple. And simple is a great way to start. And just know that we're going to add more complex ideas to it later. All right, so there's positive and negative ions. Major positive ions are sodium, potassium, calcium, magnesium. Negative ions, chloride, bicarbonate, and phosphate. So again, we're going to focus on sodium, potassium, and calcium for this course. We'll talk a little bit about bicarbonate in the acid-base portion. Sodium. Now, there are a lot of lab values that you need to know for this portion. You'll want to pull out that lab value sheet that's posted on Talon, the one that's in color, and that's got all the lab values and the specific ranges that we're going to use for the program. So normal serum sodium level is 135 to 145. What that means is serum sodium means where we're measuring it is in the cardiovascular system. So we're going to talk about changes in those extracellular compartments, intravascular, interstitial, related to fluid and electrolyte concentrations. We need sodium for chemical reactions. We also need sodium, which helps transport nerve impulses. There's a sodium channel that runs along nerve impulses. It helps with acid-base balance, and it helps regulate water, reabsorption and excretion of water. All right, excess sodium, hypernatremia. That means a sodium level above 145 milliequivalents per liter. All right, so if you think about, it's about the sodium concentration, which means I have too much sodium electrolytes and I don't have enough fluid, water. All right, so some things that cause elevated levels of sodium is I've lost all my water. Older adults that don't drink very much, someone who has had a lot of sweating, somebody who has had diarrhea, somebody who's dehydrated. Think about Iowa in the middle of the winter or in the middle of the summer when it's 100 degrees outside and how much fluid you lose in a very short amount of time. So anything that causes a lot of fluid loss could cause hypernatremia. So what is your patient going to look like when you have a high sodium level? All right, so now you have to start thinking about what's moving where because of that imbalance. You've got a high concentration of sodium in the blood, and so water is going to move from low to high. Low concentration is out in the tissues and the interstitial tissues. So it's going to start moving into the cardiovascular system to try to dilute that serum sodium level. All right, now there's varying degrees of sodium dehydration and fluid loss. Now I want you to understand early hypernatremia, their blood pressure may go up initially because they're starting to shift in fluids from the tissues into the blood to try to dilute that sodium. But I want you to think about if you get to the point where I don't have any fluid left to shift in there. Okay, so everything is wrung out and dry. I've pulled every drop of water I've got from everywhere to try to get it into the cardiovascular system to dilute that sodium level. So what's your patient going to look like? They're going to have thirst, hopefully. They're going to have dry skin. Their skin's going to be warm and flushed. Their mouth is going to be dry and sticky. Their tongue's going to have furrows in it. If you think about a tongue that gets kind of all shriveled up and there's kind of ridges in it when you're really dry, those are called furrows. So their tongue looks furrowed. Temperature is going to go up. Body needs water in order to regulate temperature. If they don't have enough water, and the sodium concentration is high and using up all the water, then they don't have enough water available to regulate their temperature. All right, I've run out of water. I've used up every drop of water that I've got. So what's going to happen to their blood pressure? If they've got low fluid volume, they've used everything up that they've got, their blood pressure is going to go down. If their blood pressure goes down, what's going to happen to the heart rate? It's going to go up. All right, they could be restless. All right, now we're going to talk about altered level of consciousness, mental status changes. Everything we talk about is could cause confusion and change in mental status. All right. So if they have orthostatic blood pressure related to their low blood pressure, and restlessness or change in mental status. So now I've got orthostatic blood pressure, change in mental status. So the thing I'm worried the most about is I'm worried about them falling down when they stand up. All right. Nursing interventions. What are you going to do for this person? Well, we want to decrease the amount of sodium in their diet. So how would I do that? Now I want you to think, when you start talking about dietary considerations for electrolyte imbalance, I want you to think about, don't just tell them they can't have something. I want you to come up with a list of things that would qualify that person could have. So what kind of foods could you offer your patient that are low in sodium? All right, so we're going to work on a list in class. All right, we want to make sure we got plenty of fluid intake. We want to make sure we do oral care. All right, we're going to do intake and output, daily weights, because that's the best overall indicator of fluid status. Make sure we're doing a baseline blood pressure before you stand them up. Cut back their sodium intake, and then basically treat the cause. All right. As you give them more fluid, you would expect their urine output to increase as you increase their fluid intake. So always think about, how would I know that my patient is getting better, that the imbalance has been addressed? All right, you're doing intake and output. Intake should be increased. Output initially will be low, and it should increase as you give them more fluid. Daily weights would increase as you fill them up with fluid. All right, hyponatremia. All right, now we have too little sodium. All right, the sodium level is below 135 milliequivalents per liter. All right, we're measuring that in the blood, so that means the blood has a low concentration of sodium. All right, causes of this, generally it's caused by an excess fluid intake. So to give you an example, probably once or twice a year you hear of some fraternity or radio station having a contest to see who can drink the most beer or drink the most water at one sitting, and the winner gets some big prize. And what happens is that person ends up becoming unconscious and ends up in the emergency room, and sometimes they die. All right, anything that alters their sodium imbalance. All right, so what's your patient going to look like? How do you know that this is going on? All right, so again, water moves from where to where? Water always moves from low to high. So it's low concentration in your blood, intravascular. So where is the water going to go? It's going to start shifting out into the tissues. So how are you going to know that? You're going to see edema. The thing that we're worried about is that you're going to see cerebral edema as it shifts out into the brain. So their brain starts to swell up, causing a change in mental status. All right. You would expect their blood pressure to decrease because the water is leaving the cardiovascular system. Their blood pressure goes down, but their weight is going up because they're retaining all kinds of fluid. Their urinary output would go down because the fluid is not in the cardiovascular system. It's out in the tissues, they're all puffy. The kidneys can't do anything about excreting that excess fluid because it's not in the cardiovascular system. All right. Fluid is also shifting into their GI system. So the GI tissues get all full of water and all irritated. So they could have abdominal cramping, they could have diarrhea, and those kinds of things. So the main concern is the cerebral edema, all right, and changes in their blood pressure. All right, nursing interventions. What are you going to do for this person? You're going to give them sodium. So what kind of foods are you going to give them? Let's come up with a list of things that are high in sodium. We're going to do intake and output, measuring their response to treatment. We're going to restrict their fluids, and we're going to give them sodium. Checking their blood pressure. And then we'll talk more specific about fluid restrictions and what that means. That means you're going to give them a controlled amount of fluid in order to cause them to be a little, in order to try to get them to increase their sodium concentration. All right, so here is the scenario. 77-year-old woman admitted after gardening on a hot summer day. Daughter found her laying on the couch, confused, unable to get to the bathroom. She's weak, anxious, and confused. Her blood pulse is 110, blood pressure is 108/58. Her skin is warm and dry. Her specific gravity is 1.028. Now, side note, normal urine-specific gravity, which is a measurement of concentration, is 1.010 to 1.030. So it's on the concentrated side. All right, so would you expect the serum sodium to be elevated, decreased, or normal? What treatment does the nurse expect? And what would be important to include in a teaching plan? Most people that have these electrolyte imbalances are going to be outside of our direct supervision. So we need to know what we're going to teach them in order so that it doesn't happen again. So I want you to go back and look at the sodium imbalances and try to answer these questions. And we'll talk more about these in class. All right, potassium. Potassium helps maintain balance. It regulates heart rhythm. It's very important for that. It helps in the neuromuscular system. It helps get glucose into the cell, and it helps with protein synthesis and acid-base regulation. Normal value is 3.5 to 5 milliequivalents per liter. Potassium is really not stored in the body very well, so we need potassium intake on a daily basis. The kidneys are the main thing that excrete potassium if we have excess potassium. And so if someone has issues with renal function, then I'm worried about them not being able to excrete potassium and having high potassium levels. All right, hyperkalemia, serum potassium greater than 5. Some of the things that cause hyperkalemia, taking too much potassium. There is a class of diuretics that actually hang on to potassium. Those could cause an excess of potassium. We're going to talk about changing an acid-base balance, renal disease, renal failure, renal insufficiency. The kidneys aren't working, they can't excrete the potassium, so they have an elevated potassium level. Too many salt substitutes, which are made of potassium, could cause hyperkalemia. That'd be a lot of salt substitutes. Then if you have an issue with high glucose levels, and we'll talk about that with metabolic acidosis, that can cause a change in your potassium levels because glucose attracts potassium. And we'll talk about that more in the metabolic acidosis acid-base section. All right, so manifestations. What's your patient going to look like when they have an excess potassium level? All right, so potassium helps with nerve conduction. All right. So if I don't have enough potassium, it slows everything down. If I have too much potassium, it excites those neural pathways, and so everything speeds up. All right, so if everything speeds up, what's going to happen in the body? The heart is going to speed up. The heart is going to become irregular. Cardiac arrhythmias are usually pretty typical with high potassium levels. What's going to happen to their muscles? Their muscles are going to speed up. They're going to have muscle twitching, muscle spasms. What's going to happen to the GI system? Everything's going to speed up. They're going to have cramping. They're going to have increased bowel sounds, hyperactive bowel sounds. They could have diarrhea. So if think about everything that's gotten sped up in the body, that's what the kind of symptoms you're going to see. All right, so what are you going to do for this person that's got neuroexcitability? All right, so you want to make sure that you keep tabs on their heart rate and their arrhythmias. We're worried about changes in muscle strength, which is a safety risk. They've got abdominal cramping and hyperactive bowel sounds, diarrhea. Worried about fluid loss, electrolyte loss. All right. All right, potassium deficit, not enough potassium. Potassium level is less than 3.5 milliequivalents per liter. Things that cause loss of potassium, not enough potassium intake. Loss of potassium in the GI system. Vomiting, diarrhea, long-term chronic can cause rapid loss of potassium. Diuretic therapy, and that's generally the number one cause of potassium deficit is use of diuretics. So anytime that you see someone that's being treated for hypertension with diuretics, you automatically assume that they are going to have a low potassium level unless proven otherwise. This is the most common electrolyte imbalance that you're going to see. So this is going to generate quite a few questions on the quiz and the exam about potassium because we deal with this on a regular basis. All right, we talked about if high potassium speeds everything up, low potassium is going to slow everything down. So everything becomes relaxed and calm. People have fatigue. They have muscle weakness. The sodium-potassium pump builds up because there's not enough potassium to exchange, so they get leg cramps. That's a pretty typical response to potassium deficit, one of the earliest things that patients will report. The GI system slows down, so they have hypoactive bowel sounds. Everything starts to back up, abdominal distension. They get constipation. They could have it back up to reflux. They don't have much appetite, so they have GI issues. Cardiac irregularities, again with the potassium imbalance. And then the other significant thing that we're worried about with this is the muscle weakness, particularly the diaphragm. If the diaphragm is weak, then you can't expand your lungs, so tidal volume goes down. And we talked about this in Unit 1. When they can't get tidal volume and the lung expansion is less, they're not getting good inflation of the lungs, they're at risk for atelectasis and then collapse and decreased gas exchange. So that's probably our number one concern is their breathing, if they're breathing okay. And how am I going to know that? Because their breath sounds are absent. You have decreased breath sounds in the bases. The leg cramps are something early that people complain about, and then fatigue. All right, so what are you going to do for this person that's got a potassium deficit? Well, the first thing you're going to do is you're going to make sure you increase their potassium intake. We want to do that besides medication. We want to make sure they get enough potassium in their diet. So you need to come up with a list of things that are high in potassium. Lots of green leafy vegetables, meats, nuts, milk, different things like that that are higher in potassium. And again, we're going to do a nutrition activity in class to come up with a food list. We're going to put them on a cardiac monitor. People are home with low potassium levels all the time. So how are they going to know that their heart rate is irregular? What you're going to do is you're going to teach them how to take their own pulse. All right, so it's not so much just the rate. What's the pattern? Does it speed up? Does it slow down? Does it skip? Does it do all kinds of funky things when I'm checking it? And to give them criteria when to contact their provider. If they develop leg cramps or they feel like their heart rate is off, that they should notify their provider. If they're having difficulty breathing, we want to make sure that they're upright as much as they can, because again, that helps with diaphragmatic excursion and lung expansion. Safety precautions, and then we want to address the slow GI system. We want to make sure they have plenty of fluids, lots of fiber. Again, that kind of goes with the high potassium foods, and activity if they're not too weak. So this is one of the little diagrams, just kind of one of those little pictures that kind of gives you a different way of looking at the information and remembering it. And here's potassium deficit. And I think it's always great when students are creative and come up with their own mnemonics like this, that they can help each other remember these kinds of things. All right, another case study. Patient admitted for palpitation. His potassium was 5.4. Yesterday he ate eggs, bacon, and toast. He had a fresh salad, and he had fish, baked potato, and spinach salad. Sounds like lots of potassium. Dried fruit and a Diet Cola. Uses a salt substitute. We talked about that. Salt substitutes are made of potassium because they have a similar taste to sodium. And spironolactone is a class of diuretics that holds on to potassium. It's a potassium-sparing diuretic. And he also has abdominal cramping and diarrhea. That all fits our clinical picture for hyperkalemia. All right, so then you're going to answer these questions. Why is he having those GI symptoms? What treatment would you expect? And what would be important to include in an education plan for this person? And again, go back and look at the information. If you want to stop and go back and look at your PowerPoints and look at the information and come up with a plan for this patient. Calcium. Normal calcium is 9.0 to 10.5. Calcium is important for nerve transmission. You need it for contraction of muscles, absorption of B12. You need it for a regular heart rhythm. You need it for bones and teeth. It also plays a role in blood clotting, in that coagulation cascade. It's related to hormone secretion and helps maintain cell membrane. It's regulated by the parathyroid hormone and calcitonin, and you need vitamin D in order to help absorb it. All right, high calcium. You've got too much calcium. Higher than 10.5 milliequivalents per liter. Some things that cause high calcium levels. Changes to the parathyroid, which alters parathyroid hormone and calcitonin. We talked about immobility in Unit 1. Remember, we talked about how it affects the bones. And prolonged immobility, the calcium actually starts leaching out of the bones. And where that calcium goes is back into the cardiovascular system. And so your calcium levels go up. Someone who takes a lot of antacids, which are made of calcium. And then people that have a type of cancer called multiple myeloma. It's a bone cancer that as it eats holes in the cancer eats away at the bone, that excess calcium goes back into their system. So someone who's got a really high calcium level, that'll be one of the first things that they check to make sure that they don't have multiple myeloma. So what's your patient going to look like if they have a high calcium level? All right, so think about calcium that covers everything up and relaxes everything and makes everything just slow down. All right, so if everything slows down, you're going to have muscle weakness, you're going to have fatigue, they're going to be slow neurologically, their GI system's going to slow down, so they're going to have decreased bowel sounds, abdominal distension, irregular heartbeat because plays a role in cardiac rhythm. And we'll talk about a class of drug that's a calcium channel blocker in the cardiac unit. Because calcium also plays a role in the coagulation cascade. If you have too much calcium, that puts your patient at risk for developing a deep vein thrombosis. So that now they have a high DVT risk. All right, and how would you know that they were developing a DVT? Remember that from Unit 1. All right, so what are you going to do for this person? So we want to make sure that we've got things on to prevent DVT, the compression stockings, make sure we're doing range of motion. We want to decrease the calcium in their diet. We want them on a cardiac diet or a cardiac monitor. We're going to do those things to stimulate peristalsis by making sure they have plenty of fluids and fiber. If they're immobile, we want to get them moving. Increase their fluid intake. Now, this one in particular, we need to make sure that they have plenty of fluids, probably at least 2 to 3 liters per day in order to dilute that serum calcium level. If it's severe enough, they might do dialysis. Diuretics also might have an effect on calcium, but it's not specific for calcium. Low calcium level, less than 9.0 milliequivalents per liter. All right. Some things that cause a low calcium level, if you have your parathyroid removed, you don't have parathyroid hormone anymore. If someone's lactose intolerant, alcohol can cause issues with calcium absorption. It has an effect on absorption of the GI system, and it changes the liver and how people absorb the calcium. Diuretics can cause it. Kidney disease. So people that have kidney disease typically have low calcium levels. And that's, again, related to changes in the GI system and the way the kidneys excrete calcium. And someone who has a decreased intake of vitamin D. So what's your patient going to look like if they have a low calcium level? So if you think about high calcium kind of smoothed things out and made everything slower, low calcium is going to have the opposite effect. It's going to make everything hyper and twitchy. All right, so changes to the GI system. They're going to have hyperactive bowel sounds, abdominal cramping, diarrhea. All right. The main concern that we're worried about is the changes in their nerve and tendon responses. So they can develop tetany, which is spasms of the muscles and the tendons. We're going to look at a couple of PowerPoints here in just a second about some specific tests to do to check for calcium. You're going to check nerve stimulation, a couple of different ways. They could have an irregular heartbeat. They would have an elevated risk for bleeding because they don't have enough calcium to interact in that coagulation cascade. So now think about Unit 1 and all those things we talked about, risk for bleeding, what kind of things you're going to do. We want to increase the calcium in their diet. So how are you going to do that? What kind of things would you have them eat? If they're lactose intolerant or they're vegan or have some other dietary restriction, now we're beyond the give them milk and cheese and that kind of stuff. So you got to come up with some other things. If the hypocalcemia is significant enough, worst case scenario, they could have a seizure. So then you'd have them on seizure precautions, which would mean a quiet room, turn off the lights, close the door away from the nurse's station, turn off the TV, close the blinds, limit visitors, pad the side rails, and those kinds of things. That would be seizure precautions. Want to increase their vitamin D, and we want to increase their protein level. So here's a picture of how the calcium is stimulated and absorbed. All right, one of the tests that we do to check specifically for calcium, low calcium level, is called Chvostek's. All right, it's Chvostek's. And if you look at the picture, you're tapping on the facial nerve on their cheek. And what happens is if they've got low calcium, that muscle spasms then, that nerve spasms, and so then they kind of scrunch up that side of their face. Chvostek's is a specific test to test for hypocalcemia. All right, this is called Trousseau's. And you can look for the spelling in your textbook. It starts with a T, it's probably French, and it's got too many vowels and consonants in it. All right, so what happens is you put the blood pressure cuff on their arm, and you pump it up, and you leave it pumped up. What happens is it stimulates and the brachial nerve, causes it to spasm, and then their arm ends up in this strange position. These are reflexes, and so they don't have any control over this. And so this again is a test. Trousseau's is a test for low calcium levels. All right. Clinical signs of hypokalemia. You can stop and look that back up. I think you should be able to answer that question. Next one. If your concentration in your blood increases, what is stimulated? That's kind of a review from the first video that you watched. Potassium level is 2.5. That would be a critical potassium level. So what nursing assessments would you expect? Select all that apply, because I know you just love those questions so much. And so I'm going to let you figure that out, and then we can talk about it further in class. And then that concludes the second video about the specific electrolytes.